to CHF pharmacology. So this is an overview slide. Each of the following slides kind of goes in detail on these medications. This is just a summary of the meds that we give in CHF. Usually our go-to meds are the ones that are going to stop ventricular remodeling, right? So that's our goal, is to stop the SNS and stop the RAS, because those are what cause the remodeling and cause the downward spiral in their heart function, right? So ACE inhibitors and ARBs, check that box because they are blocking the formation of angiotensin 2, right? As you know, angiotensin 2 is the one that's going to cause cardiac remodeling, right? So we want to stop that. And in green there, you have all these different medications that can help out, right? So ACE inhibitors and ARBs for sure. As we'll learn, MRAs or mineralocorticoid receptor antagonists. There's only one mineralocorticoid out there, so I'm not sure why they don't just call it aldosterone antagonist. But anyways, aldosterone is an MRA, right? So yeah, so we have two varieties of meds that can help block that angiotensin 2 from getting in the way, causing cardiac remodeling, right? And then we have ARNIs, which we'll talk about shortly. They are going to inhibit the, or they're going to actually potentiate, sorry, the this magic hormone or magic enzyme, I should say, and that's going to this hormone, this protein being aprilisin, and aprilisin is bad because it breaks down ANP and BNP, and we said ANP and BNP are great. So we're going to be given aprilisin inhibitors, and that's going to, upregulate ANP and BNP, inhibiting the RAS, which is nice, right? So our goal here again is to stop ventricular remodeling. And all heart failure varieties are started as some kind of anti-failure regimen. So they're on a beta blocker, ACE inhibitor ARB, MRAs, and then the new kid on the block is SGLT2 inhibitors. And have you seen SGLT2 inhibitors before? I've not discussed them yet, but they are, where do they see, what kind of patients are on these? Diabetes, right? So diabetic patients are on SGLT2 inhibitors, and it makes them pee out glucose. And where sodium goes, water goes, but second place is where glucose goes, water goes. So that sounds like a diuretic to me with extra steps, right? So that is just all you're doing is diuresing them with an SGLT2 inhibitor. It actually also diureses out lipids. Oh shoot, that's going to lower the lipid as well. So it's lowering lipids and preload. That's a great medication, all right? So it's kind of moved up all the way to like the top of the list. It's actually number 1 now. Should we start an SGLT2 inhibitor first, and then we start on the things that do ventricular remodeling, okay? So that's the idea. Then with HFpEF, that's where, again, SGLT2 inhibitors are going to work great, but also we want to give vasodilators. And we'll talk about this at the end of today regarding the different medications for hypertension. But our goal with HFpEF, we know it's caused by hypertension. We got to control the hypertension. We know it's caused by diabetes. So to give one of the 13 classes of diabetes medications, right? Or multiple, right? They can be on like 4 different PO anti-diabetic medications and insulin. We got to get the diabetes under control. Otherwise, they're going to get hypertension and develop a worsening, put at risk for MI or heart failure, right? And then we know that ASCVD is a risk factor for hypertension, so we got to nip that with statins, right? And then usually they calculate the risk score, and if it's more than, I think it's 10%, they need to be on aspirin for life at that point, because you're at risk, and then you don't want to get that collagen to be exposed in the coronary arteries, and then now you have a platelet aggregation. So we want to give aspirin to kind of mitigate that. Yes?
You were saying statins are okay with acute exacerbations, you know?
Statins are fine with acute exacerbations. What's not fine are the beta blockers. All right, beta blockers are not given with CHF exacerbations. With the other medications, you're gonna pump the brakes because you know that they can lower blood pressure if you take away too much volume, right? But once the blood pressure is stabilized, we can then start them on the anti-failure drugs. Okay. The other thing to watch out is when you have a low blood pressure or you're admitted to the hospital, you can also be admitted with a injury to your kidneys or an acute kidney injury, right? An AKI, and whenever an AKI, you're at risk for hyperkalemia. So we got to be alert to the ones that cause hyperkalemia. And once they're resolved and their kidney function is returned, then we should restart their medications, right? And then HFrEF, or systolic failure, right? Our goal is to stop ventricular remodeling and slow its progression. So again, we're blocking angiotensin 2, and we're blocking the SNS. So if we block the SNS, then the beta-1 receptors specifically are not going to be able to be activated, and when these get activated, that causes a increase in ventricular remodeling. So we're going to stop that with our beta blockers. Our beta blockers right here stop that ventricular remodeling, right? Also, beta blockers block the formation of RAS, right? There's actually beta-1 receptors on the kidneys, right? on the kidneys itself, there are little beta-1 receptors that trigger, so SNS activity, so they trigger on the kidneys beta-1 activity. The little beta-1 receptor there, so it's going to do two for one. It's going to block the beta-1 receptors on the heart, stop ventricular remodeling, slow the heart rate down, improve myocardial oxygen demand, and also it's going to block the beta-1 receptors on the kidneys, stopping the release of renin, which stimulates the RAS system. So all these things are beneficial, right? And then going back to, and then other thing to think about is, yes, reducing heart rate can also help. So we have another fancy medication called ivabradine, which can also reduce myocardial workload. Usually it's given when beta blockers are contraindicated, when they have like a block or something. And then go back to angiotensin 2. We know that beta blockers will stop its formation back all the way at the kidneys over here, right? But then how else can we stop it? Well, we know angiotensin 2 gets released by the kidney, so let's stop it somewhere. Let's stop the production of renin, right? So there are medications that actually directly inhibit renin, but they don't have good outcomes, so we kind of stop it more downstream. So we stop it with ACE inhibitors, right? They stop the conversion of 1 to 2, right? There's 2 right there. Here's 1 over here. So we're stopping the conversion from angiotensin 1 to 2. That's our goal with our ACE inhibitors, right? They're going to stop angiotensin 2, and as we know, angiotensin 2 is going to stimulate the SNS, and that's going to be a problem. So we're kind of doing 2 for 1 there. We're stopping the SNS with beta blockers, and we're going to stop it also with our ACE inhibitors. Okay, what does angiotensin 2 do? It binds to what are called angiotensin 1 receptors. All right, so we have all these different receptors right here that are angiotensin 1 receptors. So we're going to give angiotensin receptor blockers, these ARBs here, right? So angiotensin receptor blockers, obviously we're not going to have the effects of angiotensin. And therefore we're going to vasodilate, because we know that's what their first job is for. That's what the namesake is, right? They're called angiotensin. They tense angios. They raise blood pressure. They raise preload or afterload. Afterload, right? Well, it's not wrong to say preload, because this angiotensin 2 will then stimulate the release of aldosterone. Aldosterone will then increase our preload. Yes, that happens as well, right? But the direct action is to raise afterload, to raise blood pressure. Do we want a high blood pressure for our CHF patients? No. Whether it be HFpEF or HFrEF, we want the blood pressure under control. All right, so ACE inhibitors and ARBs are given for that reason. All right, so we can see that ARBs are going to cause ventricular remodeling. ACE inhibitors, angiotensin 2 will also cause angiotensin 2 causes your ventricular remodeling, and our ARBs here, right? All our ARBs are stopping that from happening. Okay, they're also stopping, and like I said, aldosterone from firing off. Aldosterone will cause ventricular remodeling on its own, right? So MRAs, or aldosterone, will cause ventricular remodeling, cause increase in preload, which is also going to put extra stress on the heart. So stopping that would be great, right? With an aldosterone antagonist, but they're not called that. They're called mineralocorticoid receptor antagonists, right? So MRAs are also used and to help with heart function, right? And then if someone still has vasoconstriction happening, we can give little vasodilators like nitrates, right? We can give, you always hear Lasix for heart failure. It has no effect on mortality. It's like just peeing in the ocean. It's not going to do anything, but you can do it. It's not going to harm anybody, right? So that's fine. You can do that, but it's not going to improve their mortality. Will it get them out of like a heart failure requiring intubation? Yes, but in the end, when they do all the data, it's not going to change things. Just like digoxin doesn't really help with someone with heart failure. Yes, it increases myocardial contractility, but you're also increasing O2 demand on the patient. So like which one is it, right? So, but what does work are our SGLT2 inhibitors, right? Our MRAs are going to pee out some fluid too, right? Because they're going to stop the effect of aldosterone, which retains sodium in water. So we're going to stop that, and we're going to help improve preload, and also we're going to help improve afterload with our ACE inhibitors or our ARBs. Our beta blockers could do the same thing. We have different kinds of beta blockers, different flavors of beta blockers. All right, so we can go into detail on each one of these medications in the next couple of slides. All right, so beta blockers. So the ones you want, just like with ACS, is the tune of NBC, right? So it's MBC, are metoprolol, bisoprolol, and carvedilol. Okay, so these are the ones that have been found with evidence that these are the ones that are actually the ones that work for ACS and for CHF. So it's one of these three. You're not going to find your CHF patient or your ACS patient on a different one. You're not going to find them on labetalol. You're not going to find them on, I don't know, a propranolol, for instance. You're going to find them on either metoprolol, bisoprolol, or carvedilol, right? And then when you talk about beta blockers, they're they were named because they blocked the beta 1 receptors. They come to find out, like the early ones also blocked the alpha receptors. But again, they already named it, just like the BNP, brain natriuretic peptide. No one's going to say that they're wrong. So they're going to say that they kept it as beta blockers, right? So it's a little bit of a misnomer because some beta blockers also block alpha receptors, right? Our alpha receptors are out in the periphery, and that's what causes our vasodilation to occur, right? So we have our beta 1 on the heart, we got our alpha 1 out on the periphery, and that will then, if you block alpha 1 receptors, which when activated vasoconstrict, that's going to cause vasodilation, right? So the reason I bring it up is because you have, you want to know which ones are beta 1 specific and which ones are non-specific. They go everywhere. So beta 1 specific are by the mnemonic man-babe, right? So man-babe, these are the ones that are beta 1 specific. They only have beta 1 activity. So you notice in our NBC tune there that we have metoprolol and bisoprolol. Those two are given for CHF, but why would someone choose carvedilol? Because carvedilol is also going to lower the blood pressure. Someone has hypertension and CHF, bing, that's a 2-for-1. Right, now we're going to lower the blood pressure, and also we're going to reduce what? Ventricular remodeling. That's our goal with these ones. Okay, so we got our metoprolol, bisoprolol, and carvedilol, and we have our non-selective ones that can be, one of them made the cut, but the other ones you might give for like high blood pressure, like a neuro patient with really high blood pressures, you can give labetalol. Is it labetalol lower the heart rate? Yes, because it goes to beta 1 receptors, but it also lowers the blood pressure. That's its primary action because it's non-selective. It's going to block beta 1, beta 2, and alpha 1. And now we say beta 2, where else do you have beta 2 receptors? In the lungs. So caution is had with who? With asthma. So I thought I had it here as well. So be cautious with those that have asthma as well, right? Yeah, bronchoconstriction right there. But the thing is, like, do you want to be, have a good heart that works, or do you want to, or you have your asthma? So they weigh the odds, right? All right, what else? So SNS is what's caused of ventricular remodeling. It's saying, hey, I can sell you a shark to look exactly like a shark. You're not going to tell your friends looks like a shark. It'll be the best shark you ever saw, right? And then they say, then it gets your SNS starts remodeling your heart. Angiotensin 2 starts remodeling your heart, right? Aldosterone also going to somewhat remodel your heart, and then it looks like this, right? So then it's nailed it. All right, that's exactly what a heart looks like. That's not what it looks like at all. So that's going to then lead to further failure, right? So the goal here is to block that from happening, block the ventricular remodeling, and block the RAS system, because we know that we have beta 1 receptors on our kidneys. So our beta blockers are going to stop that as well. Okay, so again, man-babe is the mnemonic for a patient, for beta blockers that are just beta 1 specific. So you got a man-babe right there, you got a man-baby right there, right? And it's also going to cool everything down. It's going to be like a big glass or a small glass of wine. That's going to make your heart a little less use of oxygen, right? It's going to make your myocardial oxygen demand be less, right? Because it reduces the heart rate. All right, so those are our beta blockers. And beta blockers are also given for antiarrhythmics, so don't forget, it's part of your ABCD therapy. And when you want to lower the heart rate on someone, are you going to give carvedilol? No, it's not going to. It's going to lower the blood pressure dramatically. And when their heart rate's elevated, you're worried about high blood pressure. So beta blockers that we give for antiarrhythmias are man-babe, right? They're beta 1 specific. All right, so afterload reduction. So we know we want to reduce ventricular remodeling by giving beta blockers and reducing the workload of the heart. But what else will reduce workload of the heart is reducing afterload. Afterload is what again? It's the work, SVR or diastolic blood pressure. It's the work the heart has to overcome on the other side, right? The heart has to pump and overcome the previous cycle's diastolic blood pressure. If you make the previous cycle's diastolic blood pressure lower, that's going to make it easier on the heart. All right, so we have a few different varieties. We're either on ACE inhibitors or we're on ARBs. We're never on both, right? And we're never on ARNIs with the other two above. It's one of these agents, okay? So we are going to be, ACE inhibitors are our go-to agent. It's very, very effective, right? it's going to be it's kind of like ACE inhibitors compared to ARBs. It's like about 3 times stronger, right? It's much, much better to be an ACE inhibitor if you can tolerate it, right? They all end in pril, which is nice, right? There's no like one that works better than the other. The one that works better is the one that is more compliant, right? So lisinopril you take once per day, whereas like enalapril or benazepril you might take twice a day. So that's why you already see everybody on lisinopril and not benazepril, okay? So ACE inhibitors, they inhibit ventricular remodeling because they are stopping the angiotensin 2 from going to the heart, right? They're blocking the receptors here, and they're stopping the ventricular remodeling. There's other effects too, anti-inflammatory, other fun stuff, but the primary thing is blocking that ventricular remodeling, right? What else is important about it? It might cause taste changes. It increases bradykinin. So one of the things when we give ACE inhibitors is that it will, yes, it blocks angiotensin 1 and 2, but it stops the breakdown of bradykinin. So bradykinin starts building up and building up and building up and building up, and that is a inflammatory mediator, and that's going to cause neck swelling and lip swelling and cause you to have what? Angelina Jolie lips, right? It's like, well, I want that. Right? That's one thing I would need, right? But it causes your airway to swell up, and you can suffocate because you're not getting air into your lungs. Right, so that's something we want to be alert to, that they should know that if you feel scratchy back your throat, difficulty swallowing, it could be this ACE inhibitor that you're on. Another annoying side effect is it causes a seal-like cough, right? It's a cough all the time. You can always hear it a mile away. Say, oh, you're on lisinopril, aren't you? Right? You hear this like barking like cough, right? It's not a normal cough. It's like a high-pitched cough, right? One of our night shifters is on it. You're like, oh, you're on lisinopril, aren't you? Right? So yeah, so that's a side effect of it. People just don't like it, and they might not tolerate it, or they had angioedema, and they have to be transitioned to an ARB of some sort, right? So ARBs are the ones that are given for those that can't tolerate ACE inhibitors. That's the only reason why you would be on it, besides being, what else? That's probably it. All right, so what else? So there's much less cough. There's no angioedema associated with ARBs because it works after the ACE inhibitors. And then also the ARBs, they are blocking angiotensin 1. Again, there's another one of the things that people don't want to give up. You might hear in many books, even like your drug guides, is angiotensin 2 receptor blocker. It's not. It's an angiotensin 1 receptor blocker that angiotensin 2 binds to. It's like, why don't you just call it angiotensin 2? Shh. Don't tell me what to do, right? Because it's angiotensin 1, I promise, right? So no, it's an angiotensin 1 receptor blocker that it's blocking to. It's not angiotensin 2, but actually it's actually an angiotensin 1 receptor that it's actually binding to, blocking, and therefore angiotensin 2 can't do its thing, and therefore you get a nice improvement in your SVR. So SVR would go down, right? You would reduce the resistance. All right, what else? So we have our ARNIs. Right, so that's our sacubitril we talked about. It's going to be inhibiting the RAS, right? So it's going to actually promote AMP and BMP, and AMP and BMP are our good guys. Those are the ones that we want, right? They are going to get rid of sodium and therefore water and therefore preload, and then they're also going to do what? They're also going to stop the effects of the RAS system. So you stop the effects of the RAS system, now you have less RAS activity, less angiotensin 2 activity, and less remodeling, and therefore a reduction in blood pressure. All right, so this is exactly how it works. So you have their neprilysin inhibitors. So neprilysin is trying to stop AMP and BMP, but sacubitril is the one that stops the neprilysin that's breaking down this good guy. Okay. So that's the idea behind these agents that will reduce our afterload and help the heart not be remodeled, right? Because the heart does get remodeled with the presence of angiotensin 2. All right, so angioedema. Again, we have a nice swollen lips. We have a swollen airway, a swollen tongue, and this can then cause a occluded airway, right? It's based on a true story. It's breathtaking, right? It's something that's going to be a problem. So it's an emergency. They're usually going to be admitted to the ICU for 24 hours. Like, why did I get this patient? It's because, and then they come to the ER and they got a huge swollen face like this, right? So that's a serious situation. That's a very, very difficult airway to obtain. So we want to make sure that we are keeping track of that their airway is maintained. And usually it takes about 24 to 48 hours for the medication to wash out on its own, but sometimes they need extra help. So people think that when your airway swells that it's a histamine response, right? As an allergic response. This is not allergy driven. This is someone that's not allergic to their ACE inhibitors. Although you're going to put it on the profile now that they're allergic to ACE inhibitors, because that way no one prescribes in the future. All it is an upregulation of this bradykinin that I was talking about, right? So ACE inhibitors increase the amount of bradykinins that are developing, right? ACE inhibitors stop its breakdown. They stop angiotensin 1 to go to angiotensin 2, but they also stop bradykinin from being broken down naturally by the body. So you build up all this bradykinin, and that causes our angioedema. So ways to fix it, we can give TXA, tranexamic acid, up here. So TXA is a medication that will eventually reduce the formation of bradykinins. There's some really, really expensive agents that cost about $6,000 to $9,000 a piece. That makes pharmacy, call you 4 times. Are you sure? Are you sure? Are you sure? Right, but they do have specific agents that can definitely inhibit the bradykinins and break them down. And then we have the option of just giving FFP. So FFP is also another treatment, because that's just going to dilute the plasma of the bradykinins. So you're going to diluting the reaction from happening in the first place. All right, so digoxin. So digoxin doesn't really improve outcomes. It can maybe help someone who has a fast heart rate. And if someone, especially someone has CHF, you do a little 2-for-1. It's going to reduce the heart rate, and it's also going to improve contractility a little bit. But like I said, it increases O2 demand on the heart. So increases myocardial contractility, which can be deleterious. Does it really cause increased mortality? No, but it's not going to improve outcomes either. So the other thing that it does, though, is it increases vagal activity. The vagus nerve is the opposite of our SNS, and the vagus nerve is going to cause a drop in heart rate, right? So that's the idea behind digoxin. It's going to improve contractility, so this doesn't really lower blood pressure, does it? It's going to actually improve the blood pressure a little bit. So you have a patient like a borderline, like blood pressure 92 systolic, and they say, okay, go give amiodarone, IV push, and then go ahead and get over 10 minutes, and then then start a drip. It's like, 92 is really close, right? So digoxin would be a good agent in that situation. It does require therapeutic monitoring. Usually we're not going to be on it for a long period of time. It's usually for first day or 2 or so. We have to be alert to potential toxicities, because digoxin directly blocks potassium channels. If you're hypokalemic, you have more potassium channels to be bound to, right? So you're going to get a lot more potassium channels being blocked to, therefore a lot more dig activity and a lot more symptomatic situations, right? So you're going to have this classic scooping of the ST segment. They're going to have visual changes, like Van Gogh, who overdosed on digoxin, and you're going to also have a profound vagus nerve activity. And what happens when that happens? You get a lot of nausea and vomiting, right? And of course, bradycardia, and first-degree block, and a third-degree block. So these are all consequences of too much digoxin. So yeah, it can work, but it's really, we reserve it for those that are maybe it's a borderline blood pressure. Again, nausea, vomiting, diarrhea is a consequence, the yellow halos, and we have to look at hypercalcemia, hypokalemia, and hypomagnesemia, because magnesium is what retains your potassium in the first place. So if your mag's low, your potassium is low, therefore more dig can bind to the potassium channels and cause more dig toxicity. And of course, you have more dig in your system if you can't pee it out. So that's why renal failure can also make you dig toxic. So how do you know if someone's at risk for dig toxicity? Yellow halos, but they're intubated, they're not going to tell you about yellow halos. Dig level, yeah. So let's find out what your dig level is, and then we know that it's safe to give or not. And of course, you're not going to check a dig level on someone who doesn't have digoxin already, but that's something to avoid dig toxicity. Giving it once may be cool, but then for a follow-up dose, you want to make sure you have the right things in order. All right, preload reduction. So we did afterload reduction, a little bit on dig, and now reducing circulating blood volume, right? So we want to reduce our MRAs, reduce our volume with MRAs, a mineralocorticoid, or just aldosterone. We're stopping a function of aldosterone, its normal function, right? So we're going to inhibit aldosterone, therefore we are not going to do what aldosterone does normally, which is what? Aldosterone normally binds to sodium-potassium channels, right? So it binds to our sodium-potassium channels right here, and it takes sodium in exchange for what? Aldosterone is going to potentiate sodium into the bloodstream and potassium out of the bloodstream, right? So you're going to pee out potassium. It's your only way your body can get rid of potassium. There's no other hormone, other mechanism to do that besides pooping a lot, right, or sweating a lot. So the only way to get rid of potassium in your body is to use aldosterone naturally. So therefore, the side effect of blocking this function, right? So if we block this with an MRA, that's going to cause a hyperkalemia. So caution is had when someone has kidney failure, right? Acute kidney injury, I should say. And it's going to block aldosterone, but this indirectly stops angiotensin 2 from doing its thing on the heart. So it stops ventricular remodeling as well. So usually you see patients come with CHF, like really bad CHF. They're on an MRA, they're on a beta blocker, they're on an SGLT2 inhibitor, right? Or they're not, and also on either an ACE, ARB, or ARNI. So they're on all these things to help prevent this ventricular remodeling and help control their blood pressure, help control their preloads. Okay, loop diuretics we mentioned, right? Doesn't affect the progression of CHF, has no benefit there. But in the hospital setting, yes, it can get them out of, it can help avoid them from getting intubated, help them oxygenate a little bit better if we can. And how do they work? They block the sodium channels in the loop of Henle. That's why they're called loop diuretics. We have furosemide and bumetanide, or Bumex and Lasix, right? And how long do they last? Lasts 6 hours, right? That's why it's called Lasix. So it's going to be, it's a diuretic we can give, twice a day, 3 times a day to help, get rid of extra volume that might be circulating. And of course, the side effects are that it's a potassium wasting diuretic, right? So they will touch base on diuretics coming up in hypertension. And then we have the new kid in the block, our SGLT2 inhibitors, right? These guys are seen in diabetes, but they come to find out that our diabetic patients with CHF are doing great. So they said, whoa, shoot, let's look at the research, and sure enough, it's getting rid of lipids, it's getting rid of glucose, and water follows the glucose, so it's kind of like a diuretic. So it's actually made its way to the top of the list as far as our CHF agents are concerned, right? And it's blocking this little transporter, little SGLT2 transporter that's in the kidneys. It blocks it. It blocks the, usually the kidneys pull back glucose, it pulls back sodium, pulls back other nutrients, and puts it back in the bloodstream, but you block the sodium glucose-like transporter, or SGLT2 transporter, and it's going to keep the glucose in the urine, and therefore water will follow it, and we get a diuretic effect. And then our last thing to do preload-wise is to give nitrates. But I thought nitrates vasodilate. Isn't that going to reduce afterload? They do, but they also significantly reduce preload, right? So your nitrates, you get, there's blood volume that's pumped out to the system, right? And then to the arterioles. And yes, nitrates are going to vasodilate that. But what nitrates do that other drugs that don't do, that beta blockers don't do, that ACE inhibitors don't do, is that they also vasodilate the venous side. So less blood returns back to your right atrium. So they venodilate and arteriodilate, whereas beta blockers, ACE inhibitors, ARBs, they all arteriodilate. Okay? The cousin to regular nitrates, such as isosorbate nitrate, is hydralazine. Hydralazine, you could consider a nitrate. It actually it potentially has the same mechanism. So we have hydralazine over here on the right, right? Hydralazine's right here. Here's our isosorbide dinitrate on the left. Isosorbide just provides more nitrate to stimulate the nitrate cycle, which vasodilates, right? And then we know that free radicals inhibit that and cause vasoconstriction and bad things to happen. Hydralazine stops that from happening, so it's indirectly causing more nitrates to be made. All right, obvious side effect is hypotension, and they can't be taking our PDE3, PDE5 inhibitors for erectile dysfunction with this. And then lastly, we talked about ivabradine briefly and digoxin. So ivabradine is another agent to help reduce workload of the heart. It's going to reduce the workload of the heart by reducing heart rate. Okay, so again, up here we have kind of overall picture. We are arteriodilating. We are reducing what? When we dilate the arterioles? Afterload. So you're reducing afterload. When you are vasodilating on the artery side, you are reducing the workload of the heart by helping it unload easier. You're reducing the diastolic blood pressure. Diastolic blood pressure is a function of how squeezed you are, right? How squoze down you are is if you're really, really squeezy, then that's going to make it really difficult to perfuse the system during diastole. So your diastolic blood pressure goes up, that's your afterload, right? And then on the flip side, we have diuretics that can work directly in the kidneys, right? In our kidneys, we can work and we can get rid of extra fluid with MRAs or SGLT2 inhibitors. Sure, furosemide can work too. So all these ones are to get rid of extra volume, right? And then on the flip side, returning back to the heart, right? We can venodilate, right? We can dilate with our nitrates, for instance, hydralazine.